We're looking at the MSDA tests by Octave, and really trying to bring precision care to multiple sclerosis patients. Particularly in this case, involves using serum biomarkers, different protein levels that identify and predict relapses, essentially. And using this has been a really powerful tool, and I think the session was basically discussing how this has impacted our practice already. So it's early stages, early in its infancy, early development of this type of testing, this type of approach to treating MS patients. But despite that, we've found the tests to be very helpful already in helping our patients and making clinical decisions. Yeah, I think having all the amount of research that has been developed at places like ECTRIMS and presented at ECTRIMS has really lent MS space in particular to development of biomarkers. This includes imaging biomarkers, includes serum, or what we call fluid biomarkers, as well as other types of biomarkers as well, and better patient monitoring. And that really is beginning to shift the focus from population health, which is really how we've been approaching and treating patients, generally speaking, towards a more precision, personalized care. That's really exciting. I think one of the exciting things, the exciting potential of fluid biomarkers, particularly this particular MSDA test, is that it's very proactive in nature, whereas a lot of previous ways of monitoring patients is very reactive. So once the damage has been done, we can see that on MRI, or we can see that on clinical disability progression. But some of these fluid biomarkers potentially can predict either relapses or even in the future disability progression, and so we can be more proactive about how we treat patients. It does require using all of our tools together, right? So I would never use just the fluid biomarker tests on its own. It's in combination with MRI imaging, in combination with your clinical tests and clinical exams. That still remains very important. I think will remain important for the foreseeable future. But I think things are accelerating. One of the things with the MSDA test is the ability to have a panel available, so not just one protein level that can be modified by many things. So for example, neurofilament light chain is affected by a myriad of different things that affect the brain as well as the peripheral nervous system. But having a whole panel of tests reduces the noise that exists with looking at just one test. And so that's one of the exciting things. So being able to test for so many different things all at once, that's a relatively novel and new approach, and it requires relatively new technology to do that, essentially. So that has helped accelerate things as well. I think that some of the data is not quite there yet. So Octave has looked at the predictability of this test and sensitivity and specificity in terms of predicting relapses in a general kind of MS population. However, some of the efficacy data hasn't been produced yet, and that they are working on. Meaning, if we act on this test, does that lead to better outcomes for our patients? And that piece of data is not quite ready there yet. There are studies looking at that, even some trials that have looked at that, or planning to look at that. And so that data is forthcoming. And that will be sort of the next piece of data to sort of confirm that using these tests as an actionable piece of data is very useful, helpful for our patients. The other piece of it is, again, the variability. So there are some patients that are outliers on the test, and it's hard to know exactly what to do with those patients. So not everyone behaves like a typical MS patient, and in fact, a lot of patients don't. And so it can be difficult to know what to do in those particular cases as well. And the final thing is that because we're measuring serum or blood levels of these markers, other things can affect the outcome of the tests as well. Again, part of the beauty of the MSDA testing is that there's 18 different biomarkers, and it helps reduce that noise. But other things can potentially shift the levels of these proteins. And you have to rule those things out. You have to think about that clinically. You have to remain a physician and not just someone reading a report and continue to treat the patient.